Well, here we are at a conference, or there we are at the bedside. We're caring for patients, we're teaching, we're learning, we're sharing our experience so that we can all get better at this. It's important because emergency medicine is complex. No other specialty in the house of medicine is at its baseline so saturated with decision points. And each of those decision points can send us or our little patients on a different trajectory. We work in a controlled chaos, and we love it. We take the dizzying array of presentation and the undifferentiated patient, and we come up with a working plan, because we're a practical specialty. But we're a visionary specialty as well. Emergency medicine was fashioned out of the need to take care of anyone, anything, anytime. Pediatric emergency medicine was formed out of the glaring disparity in how we took care of children. It wasn't long ago when an ambulance would show up to an emergency department with a sick child, and the paramedics were told to get back in the rig, go down the road, and go down to the next hospital because hopefully there they had the right staffing or the right equipment. Luckily, those days are behind us now, but we still have a lot to do when it comes to pediatric readiness. Part of that is what we're doing right now, to think about the hows and the whys of what we do. Because a lot of what we do is just pattern recognition, right? We see something, we do something. And that works for the most part until we see someone who's very sick in front of us, or the pattern doesn't quite fit. So what I want to do is talk about harnessing our inner strengths, what we already have inside us, so that when you feel that foul cloud of anxiety starting to reach forward, you can tame it into a sweet-smelling ether of success. It's 3 a.m. in the emergency department, and you've worked through your long list of patients waiting to see you, and a lot of them were sick. Some of them were the worried well. When you get a radio call that they're bringing in a 4-month-old with stridor, they'll be here in 7 minutes. That's all that you got from them, but you sensed a bit of panic over the voice on the radio. Think back to the last time you felt totally unprepared. You may have felt overwhelmed, or how do I get myself out of this situation? Okay, back to our patient. He's going to be here in 5 minutes now. Do we have our resources ready? Does the charge nurse know? Do we have respiratory therapy ready? Do we have our equipment? Do we have our medications ready? What am I getting at here is that we shouldn't go into autopilot mode. We're trying to figure out how to use our street smarts, or what other people would call situational awareness. Situational awareness is a state of vigilance and being prepared for a future condition. It's taking the information available, it's interpreting the current state and seeing what could go wrong. In this case, we're gathering the troops. We realize, we sense, and we trusted that instinct that something was not quite right, something didn't quite fit. So the child arrives. You take that first snapshot. That first snapshot is rich in information, in the visuals, and in the auditory things that you see, because as soon as you start interacting with the child, you've changed the examination. And you realize that the child is not actually stridulous. He has his neck flexed, tidal volume is poor, and you realize this is an airway obstruction. So you listen to the paramedics, but if you see something wrong, you do something about it. And we realize that this is not quite what we would expect. It's normal for an infant to be on his back. That is what we recommend as the sleeping position to try to decrease the incidence of sudden infant death syndrome. But in states of distress or altered mental status, or what we do to patients, we give them procedural sedation, we can see some abnormalities in ventilation. So what do? We take a simple piece of equipment, low tech, a towel, we fold it behind the scapulae, and we give them a shoulder bump. We align the oral, tracheal, and pharyngeal axes so that we have normal oxygenation and ventilation, because children are respiratory creatures. If we can get their oxygenation and their ventilation working, we're halfway there. Now, the paramedics are not going to be there forever, so we have to extend our situational awareness to the pre-hospital setting. We have to have them be our eyes and ears. What was going on at home? Who called? What did the home look like? Was it in disarray? Was there evidence of abuse or neglect? Was there drug paraphernalia around? What else can we gather to do a better job at taking care of this child? So despite your best efforts, the child becomes apneic. You take your finger pads and you run it along the bony edge of the jaw, and you bring the face up into the mask, and you squeeze the bag until you see tidal volume, and you repeat this mantra to yourself: squeeze, release, release. Squeeze, release, release. It prevents hyperventilation, and it calms everyone down. We try not to use our fat, stubby fingers to obstruct the soft tissue as well. And then you think, okay, well, I guess I have to intubate. Am I ready to intubate? Is the child stable enough to intubate? And you realize, wait a minute, stable enough to intubate? Do you have to do it right now? You're oxygenating, you're ventilating. You use those street smarts and realize he looks a little bit dry in his mucous membranes, and he's a little floppy. If I were to jam in sedatives and paralytics, I could take away whatever compensatory mechanisms he has, and he could become hypotensive. So you're aware of your environment, and you realize at your arm's reach, you have normal saline flushes. This is a 4-kilogram child, so if you take those 10 ml syringes and you push 4 of them in within 30 seconds, you have a 10 ml per kilo bolus. You can repeat that in a minute, and now you've used your street smarts to resuscitate before you intubate, and you avoid disaster. So a child in extremis doesn't come in every day. We have to practice our situational awareness, and I would give you this as a homework assignment to do. The next time you see a child with a completely stable presentation, make this visit also beneficial to you. Think, what would I do if he decompensated in front of me? Okay, he's 8 years old, so age over 4 plus 4, that gives us a 6.0 ET tube uncuffed, so 5.5 cuffed. Let's see, he's greater than 40 kilos, he's gonna need the adult IO, and all of those things anchor you into the moment, because we never know when people come in who could deteriorate. But it also helps to buffer you up with your reflexes so that if you don't have time to think, you've already given yourself that extra awareness. Remember that observation is our first intervention. And we're looking for red flags, any little subtle findings that we can point to that we can go down and address. Mother brings in a 9-month-old who comes in, and mom says, you know, I think she has a cold. I have a cold. Older sister has a cold. And I just want to make sure she has a cold because I think she has a cold. And you think she has a cold too, right, doctor? Because we're going to go see the grandparents tomorrow, and we want to make sure she doesn't have a cold. So they're leading you kind of down the primrose path, and okay, heart rate is 150, but it's fussy. Respiratory rate is 20, but then everybody has a respiratory rate of 20. And you're glad that you paid attention because there's a little more belly breathing than you would like, and you pull up the onesie and you see that there's some moderate retractions. She's right, there is a lot of nasal discharge, but this is not only an upper respiratory tract infection, there's some lower tract infection as well. And you took that extra moment to figure this out. The motto for children is play or die. They don't want to be sick. They compensate very well for their illness. We're looking for the subtleties. In adults, disease is dumber. It's more obvious. It's going to be obvious with a vital sign abnormality, or they're going to be very vocal about it. You're not going to miss it. So in adults, we want to ratchet up our specificity, this laundry list, and find out what can I do for you today. Whereas in children, we want to increase our gain. We want to try to increase our sensitivity so that we can pick up on early disease, which is hard because parents will often bring in children very early on in the encounter, and we can't have the hubris to think that we know everything in that slice of time. So take a minute to absorb the moment. Practice your situational awareness. All right, now we're very aware. How can we use this tool to keep our patients safe? Clarity of mission. Resuscitation is awesome, right? Everyone wants to learn how to put anyone on ECMO, pre-hospital, hanging from the side of the cliff, upside down. You get bonus points if while you're doing this, you're listening to an awesome podcast at 2 times speed. But we're always struggling with trying to toggle between resuscitation and reassurance. The opposite is true, and that you might feel the pressure to do more. We can sometimes feel like we're an outpatient rapid workup clinic for chronic diseases, and we want to be compassionate and helpful, but all the time that we're spending on non-emergencies, there are people in the waiting room that are very silently decompensating. So we have to be clear in our mission and detect the dangerous diagnoses and treat them. Because the truth is, they're not all fine, but then again, they're not all dying either. Each of us has his own internal bias, and we just have to have some examination of our own conscience to realize where we are. I have it, and everyone here has it as well. Okay, let's take a common complaint of fever without a source, right? This is after a good history in physical, and you can't pin the fever on anything. So what do? Well, it depends, right? If this is a 3-week-old, the answer is everything. If this is a 3-month-old, well, that's a more nuanced discussion. If it's a 3-year-old, if we're worried, we investigate. If we're not worried, a little reassurance. The goal in neonates is to protect them from serious bacterial illness. So we try to do everything we can to look in every orifice and every body fluid to see if it's infected. If you think about it, a neonate developed in a totally sterile environment. He has passive immunity from his mother, and now he's bombarded with a coughing, sneezing, infectious disease-laden world. Whereas a 3-month-old or a young infant, well, the goal is to try to balance the decreasing risk of serious bacterial illness, of invasive disease, with the increasing incidence of more benign findings. So a 3-month-old, the blood-brain barrier is forming well. Hopefully he would have received his 2-month pneumococcal vaccine, and it takes about 2 to 4 weeks for that to confer any benefit to the patient. So we're starting to get safer here. A 3-year-old or so, young child, well, if you're worried, then investigate. If not, it's okay to agree with grandma that it's a cold. Take the 4-year-old who has nausea, vomiting, diarrhea. Little sister has nausea, vomiting, diarrhea. Mom is starting to look a little green too. And you think, okay, well, he has normal vital signs, a really good abdominal exam, GU exam is great. I'm going to give some treatment, I'm going to observe, and I'm going to reassess, and maybe just some precautionary advice. But you have that mission creep. You feel the pressure from the referring physician or from the parents or from yourself, and an IV bolus is just a little click away. Or is it, right? And then labs are a little click, click, click away. Right? Labs are like, they're a beautiful thing. They're like chicken soup to the clinician's soul. We feel so good about them. But now you have to go and explain to the parents why the white count is high, why the bicarb is low, why the anion gap is elevated, and what could have been a nice visit where you both connect, explain, come up with a plan together. Now you've given them a type of medical post-traumatic stress disorder because they're taught that every time Johnny is sick, he needs an IV and he needs labs. Meanwhile, Johnny is skating down the IV pole in the hallway and everything is fine. So there's that disconnect there, right? This has been said many times, but we'll say it again. It's far more important to know what person the disease has than what disease the person has. So to develop this line of thought a little bit further, with labs, adults have time to develop all of these problems, and screening labs are maybe appropriate. For a child, if we did routine screening exams on every child that came into the Peds ED, it would just make it a standstill, right? We would never be able to get anything done. And we realized that a caged toddler is like an adult on PCP. It's not going down without a fight or without a show of force. So we just have to remind ourselves, what are we doing this for? Are we really truly doing it for a potential benefit to this child, or are we doing it because it's maybe benefiting us? And there's a slippery slope when you don't realize it all the time. Presence. It's the extension of oneself into the environment. What we're trying to do is share our best selves with people who need us. It's not just leadership, but it's being there for the person who needs you. Think about a trauma resuscitation and think about all the cooks in that kitchen, and that kitchen is getting smaller, the cooks are getting multiplied, and it's getting louder and louder. A 3-year-old is being pushed by his aunt across the street in a stroller when an SUV comes barreling down, sideswipes the aunt, the child gets hit and is flown several meters forward. The paramedics arrive, he's pulseless, he's apneic. After a round of CPR, they miraculously get a pulse back. And I say miraculously because for those of us who take care of adolescents and adults, if you have traumatic full arrest from a blunt mechanism, the mortality pre-hospital is really approaching 100%. It's not like penetrating trauma in which there's some reversible finding where you can stick a finger in it or put a stitch in it and try to temporize. If there's global damage with traumatic full arrest from a blunt mechanism, you're in trouble. right? This is different, though, with children. And we talked about how children are respiratory creatures. This is actually a primary respiratory event as well. He has something we don't talk about very often, but it's called impact brain apnea. We know that the force of the blow is proportional to the duration of the apnea. The double whammy happens when you have your catechols at baseline are increased 500-fold. So now you have this heart beating in an acidemic environment, and you pour catechols all over it, and you're only asking for dysrhythmias and complications. What's the treatment? Oxygenation and ventilation. Polytrauma in major trauma is the norm. And so if you have a child who's lower down on the ground, you think of that mechanism. He gets hit here, where his femur is, then he then is propelled up to the hood of the car, he sustains thoracoabdominal injury, and then when the car stops, he gets flung forward and he receives head injury as the tertiary injury. So now you have hemorrhagic shock, possibly neurogenic shock in an acidemic environment. This is where it's important to know what the normal anatomy and physiology of a child is, as well as what the pathophysiology is, because we have to realize that they are masters of the systemic vascular resistance. They can compensate very well. Hypotension is such a late finding. And once you take away the pain and the anxiety, we realize that in trauma, tachycardia is shock. This is where presence comes in. Trauma surgeons are very good at what they do, but they're very used to taking care of adult trauma. We have cookbook medicine for that, protocols, and it works for the most part. In children, though, it can be a little different. And what you can do is you can share your knowledge of impact brain apnea, share your knowledge of compensated shock, and transmit that to the room. You're not taking over. You're just sharing your best self. You're declaring the life threat. You're thinking out loud. You're helping the team to work together. The last thing I want to talk about is respect. Respect for all of us around, respect for parents, and communication. An 11-year-old is brought in by her mother because she's been vomiting all day. Mom says she couldn't keep anything down. They went to the pediatrician in the morning, and the pediatrician gave some unknown antibiotic. Child threw that up, and she comes to you looking listless, tachycardic, soft blood pressure, and she's febrile. Her capillary refill is delayed. She doesn't look good to you. What does she have? Septic shock, right? So you're aware of what's happening. You're clear on your mission. You need to get IV access. And you're present. You explain, after 2 attempts at IV, we're going to IO. But you have the respect for the rest of your colleagues, not to just declare and walk away, but to jump in. You place that intraosseous. You give 20 mLs per kilo. You give another 20. You give up to 60 mLs per kilo in septic shock. The heart rate improves to 140. The child brightens a little bit, and you feel comfortable enough to step away from the bedside, order antibiotics, get the admission process going. Until you're called back about 20 minutes later, child looks worse, no urine output, and now we're talking pressors. So we know recently that dopamine is not a good drug. In fact, it's associated with increased morbidity and mortality. It's something we should probably abandon. But what are we going to do? We need to choose the right pressor for the right condition. In adults, 80% of septic shock is warm shock. It's distributive shock. We need something to increase their systemic vascular resistance, so we use norepinephrine, noradrenaline. In children, 80% of septic shock is cold shock. They've already done everything they can to compensate. So if we pour on something more that has more alpha effect, it really is not going to do much. We need something more central, a beta agent, something like epinephrine. So often we'll say cold shock epi, warm shock norepi. So cold shock adrenaline, warm shock noradrenaline. We can use any peripheral line as long as it's free-flowing for at least the first couple hours. Now, all of that is a great plan, but none of it's going to happen if your team doesn't know what you're thinking. Acute care nurses are lovingly territorial, and they're smart. And if they don't know what you're doing, they're going to come back to you and ask, what's happening? I need to be clear on this. And that could cause delay. I would hope it's that case, and not that they don't trust you and go ask somebody else. That's going to delay even more. So if you take that moment to explain what you're thinking, maybe you're missing something. Maybe they found something because they're at the bedside longer than you are. Maybe there's a plan you can come up with together. You respect, you communicate, and you can supercharge your care. Now, respecting communication is not just for the trauma bay. We do that as much as we can with our parents. They're not here for an antibiotic or a prescription. They're here because they want us to be present with them. They want us to be clear in our mission. They want us to be available and to communicate with them. So, for example, mom comes in and she's worried about Janie's headache. And Mom, I always think of the worst thing first. I think about meningitis as well. Let's see how Janie's doing. Janie, do you have a headache right now? You do? Okay, great. Janie, when you have a headache, do you want to go to school? No, you don't? Okay. Mom, it looks like her neck, and she's able to move her neck nicely. It's nice and supple. That's a good sign. Janie, I hear that you like to put basketballs in your ears. Is that right? Let me go take a look. Is there a basketball in there? Nope, just you. Mom, her ears are clear. So you can use the child as a template to show mom and dad what you're thinking, what you're doing. You do a lot of work. You might as well get credit for it, right? Explain to them what you're doing. It also shows that you love what you do and you love the children in front of you, and it really helps to make that bond. Now, we don't need a vignette to explain the power of gratitude. Thank parents for coming in. They're worried and they need to feel confident in their skills. If we can buttress up their strengths, we can make them more effective parents at home, and then everyone does better. Use that gratitude at work. Cultivate a culture of caring and understanding amongst each other. That IV that you got in, it was so helpful, so fast. Thank you so much. Something specific at the point of care, and also at the end of the shift. Thank you, everybody, for such great work. When you do that, we respect, we support each other. It's a better place to work, it's a more pleasant place to work, and it's a safer place to work for patients. So when you feel that foul cloud of anxiety starting to arise, remember your ether catchers, your situational awareness, clarity of mission, presence, and respect. Learn it, teach it, share it with others. And soon I think you'll find that you have a safer, better pediatric resuscitation. Thank you very much.
Do you want to get up? Should we go up to the top? Do you want to stay sitting here? All right, thank you very much, Tim. So Tim had lied to me. He said that presentation was going to go on for ages and I should get worried, but he nailed it in 20 minutes.
I did my motor mouth. As you can tell, you can hear it.
So we probably have time for a question. Is there anything?
So lots of people on Twitter are paraphrasing, but this is actually not for Tim. This question is based on Tim's talk, but for Glenda. Tim spoke about communication with families, in particular parents. Do you have any comment on communication or how you were communicated with, or any advice you can give to doctors?
Yeah, I'll...
Microphone, please.
I'll tell you an interesting story. The occupational therapist who was fantastic when we were going through, and everyone communicated very well, said, call on me, I'm here for you, and she really was. But right before the surgery, Conrad really, really needed her more, and she was really stretched, and she couldn't quite be there. And I think it was interesting when you were talking about communication with families, because you can become a little bit over-dependent on the communication as well. So there's a continuum of not enough information through to where you become a little bit too dependent as well. And I guess it's that happy medium you have to find of the respect for what you do and empowering them and understanding that you need to know as much as you need to know when you know, but you can't kind of step over that line and expect that you're going to have everything all the time. But I really liked your presentation, because as a mum and a family, gosh, if someone is communicating and making it explicit, you're involved and it's collaborative and you're participating in the process, then that helps a big deal.
Okay, thank you.
Excellent. Okay, so thank you, Tim. Tim speaks a lot of sense. He wrote a blog about heart disease in children and children who have myocardial infarction, which I tweeted him about, saying, you don't need to do troponins in children. It's a waste of time. They never have heart attacks. And 2 days later, I was dealing with a 4-day-old who'd had a myocarditis and had an MRI basically in front of me with a troponin of 40,000. So that put me in my place. So thank you, Tim.